We have more refined and tailored treatments for patients with gastroesophageal adenocarcinoma based on these biomarkers.
That's Dr. Manish Shah with Weill Cornell at New York Hospital. We have more from him up next. Welcome back to the award-winning Cancer Buzz. I'm your host, Summer Johnson. We've been featuring discussions on emerging biomarkers here on the show, and today we're talking about Claudin 18.2. This biomarker is earning a lot of interest in the oncology community for its effect on treatment direction for advanced gastric cancer and gastroesophageal junction, or GEJ cancer. Claudin 18.2 marks a critical opportunity for novel targeted treatments, which can mean more effective and less toxic treatment for patients with advanced disease. Here's Shah.
So Claudin 18.2 is a cell surface protein. It's actually located at the gap junctions. And the analogy that I use is that if you imagine the cells kind of lining up like a picket fence, and the joints between the posts of the picket fence, those are the gap junctions. So Claudin 18.2 are in those facets between the posts of the picket fence or cells. And when cancers develop, you kind of lose that structure and those facets become exposed. And similarly, Claudin 18 becomes exposed and you're able to then target it with antibody-targeted therapies like zolbetuximab.
Dr. Shah, what factors are you looking at when you're determining if this is a suitable option for your patients?
Because it exists in the gap junctions, when you do a stain for Claudin 18.2, you normally wouldn't see it. But when the cells are exposed, you get an increased expression of Claudin 18.2. So I think a key factor is actually if you have a high level of expression, it's defined as 75% or higher of the cancer cells expressing, with a good intensity. So the intensity scale of 2+ or 3+, this protein Claudin 18.2. And I think the other factor that we consider is the expression of PD-L1. PD-L1 is typically scored by something called CPS, or combined positive score, but you can also use something called the tumor area positivity TAP score. But essentially, if you have a high PD-L1 score, either CPS or TAP, then you might consider immunotherapy, even though you might also have a high expression of Claudin 18.2. So you need kind of both biomarkers to kind of guide your therapy. And we don't know actually if you're high for both, if targeting Claudin is better than targeting PD-L1. I think that those studies need to be done, but knowing both will help guide your therapy.
Describe the randomized phase 3 spotlight study on zolbetuximab in combination with the chemotherapy modified FOLFOX6 and what it adds to our clinical knowledge on the value of Claudin 18.2.
So there were two studies, actually. Spotlight looked at modified FOLFOX6, and GLOW looked at Capox, or capecitabine and oxaliplatin. Capecitabine is an oral form of fluorouracil. So really, FOLFOX6 and Capox are considered equivalent. They're just given on slightly different schedules. And both of these studies were randomized trials looking at the standard chemotherapy, either modified FOLFOX6 or Capox, with or without zolbetuximab. And both of the studies were remarkably, similar in terms of effectiveness. So it turns out that both the progression-free survival as well as the overall survival improved with the addition of zolbetuximab by about 25% for both categories. So it means that patients who are overexpressing Claudin 18.2, if they received zolbetuximab with chemotherapy, either modified FOLFOX6, which was done in the Spotlight study, or Capox, which was done in the GLOW study, if you add zolbetuximab to either of those regimens, you can get an approximate 25 to 30% improvement in survival with zolbetuximab.
How do you partner with other members of the multidisciplinary care team to make sure patients receive a full biomarker workup that includes Claudin 18.2 immunohistochemistry?
So it is really critical to kind of work with your group and your team to make sure that the biomarkers are being tested regularly. We've known for over a decade that we need to test gastric and gastroesophageal junction adenocarcinoma for HER2, because if you're HER2 positive, you would get HER2 directed therapy in combination with chemotherapy. Now, since the fall of last year, so for about a year, we've known that if you also express Claudin, you need to consider Claudin 18.2 directed therapies.
How are these novel biomarkers changing the treatment horizon for gastric cancers?
Instead of lumping all gastric cancers into one group, we use these biomarkers to split them out and say if you're for example, Claudin 18.2 overexpressing, maybe you should consider zolbetuximab with chemotherapy, either CAPOX based on the GLOW study. But if you're Claudin low and you're PDL1 high, you would consider immunotherapy with chemotherapy, and that could be either nivolumab or pembrolizumab with chemotherapy. So I think we have more refined and tailored treatments for patients with gastroesophageal adenocarcinoma based on these biomarkers.
What's important for the cancer team to keep in mind when working with biomarker testing?
I think sometimes, there's a concern that there's not enough tissue available for the biomarker testing. So working with your gastroenterologist to make sure that a good amount of tissue is collected. Stomach cancers are tough. Sometimes they create a big mass and it's easy to get tissue. Sometimes they grow within the wall kind of as individual cells. And you can't always tell. So I often talk to my gastroenterologist and ask them to get more than one biopsy to make sure that we have enough tissue for now and even in the future.
Dr. Sasha Watson is a clinical pharmacist at the Sylvester Comprehensive Cancer Center at the University of Miami in Florida. She works in the GI and sarcoma clinics. When we spoke with her, we also got 2 bonus puppy guests.
Their names are Dora and Jimmy. Both of them are rescue dogs. Dora is probably about 8 years old. She's a black lab. And then Jimmy is probably about 3 or 4 years old. He's a little warrior. He's maybe like a Jack Russell Chihuahua kind of mix.
So you might hear Dora and Jimmy pop up on the show. Watson agrees with Shah that engaging the whole multidisciplinary team in biomarker testing is critical, and when it comes to coordination, there's a lot to consider.
In the clinic, there's different groups involved, like our pathologists, our oncologists, first testing for Claudin 18.2 and other markers in these patients. And then there's also, our APPs, our pharmacists in the clinic that are helping to screen patients to make sure they might be good candidates for a targeted treatment like zolbetuximab, helping with patient education, ordering the treatment, and really customizing it specific to the patient.
Infusion centers come with their own set of considerations. The infusion takes a long time, especially if it's administered the same day as chemotherapy.
So we've had to work with our managers in the infusion centers as well as schedulers, first to help accommodate the chair time for patients. Nurses in the infusion center are a huge help that, we absolutely need, and administering this treatment would be very difficult if we didn't have, skilled and experienced nurses here. So they help to actually administer the drug, monitor patients. One of the unique things about the zolbetuximab infusion is that it can cause acute nausea in the chair, which is a little bit unique compared to other treatments we've been giving. They also help with patient education and really building the relationship with patients as they receive the infusion. And then, of course, we also have a set of pharmacists and pharmacy technicians in the infusion center that are helping to confirm the correct dosing, whether it's a loading dose or the maintenance dosing, and certainly compounding the drug.
Her team has a few strategies to prevent nausea.
First is our standard order sets are built to use a combination of 4 different pre-medications to prevent nausea. So we're using olanzapine, an NK1 inhibitor, a 5-HT3 inhibitor, and a steroid, all to prevent nausea. And then we also have a series of medications built in to use as needed in case they have any nausea feeling in the chair. And then we also send patients home with multiple prescriptions to take as needed in case they do have nausea once they're home. And then another thing we're doing is with the infusion rates. So the FDA recommendation for administering zolbetuximab actually provides a range of the infusion rate. And at our center, we decided to actually infuse it on the slower end of that range, since that is suggested to reduce the nausea.
Watson and her team follow guidelines here.
So Astellas actually came out, it's called the Delphi panel that they published, which included a subset of recommendations from centers that administered this on the clinical trials. So we are following pretty closely those Delphi panel recommendations for our nausea vomiting prevention and treatment as well.
This infusion is something patients have been eagerly waiting for, so it's a good practice to plan ahead to confirm the infusion centers can accommodate the patient.
Anytime, of course, there's a novel drug approved, it really just gives all of us, especially patients, hope. So one patient in particular, we had had been tracking the FDA approval of this drug for over a year. Every day they were looking to see and asking us, is it FDA approved yet? Is it ready? Can I receive it? And so the day we got FDA approval, they reached out to us. We actually had to fight with the insurance going back and forth. So it took us a while to actually get it approved, but they were just beyond happy and excited when it finally was available. We got the insurance to approve it and we scheduled their first dose. So I think what I see is just a lot of patients having hope, some new part of their cancer that we can target with a drug that we previously didn't have any options for.
This is a developing field.
It's a really hot topic, I think, in this disease space too. It's a good problem to have, but we're also trying to figure out, say a patient is positive for immunotherapy markers, like they have high PD-1 expression. Say they're also HER2 positive, and say they're also Claudin 18.2 positive. What do we do in this case? What treatment is best to give first? So that's always a discussion, based on the clinical data that we have, as well as tailoring it for the patient. What treatment might they tolerate best too? So that's something I'm always looking at in my workup of patients is checking the biomarker testing, because it opens up a whole range of other treatment options aside from just standard chemotherapy for these patients.
Digital tools can help streamline that process.
Something that different centers and different tissue testing companies are doing with the EMRs is helping to integrate these results into the system. So at our center, we use Epic. So whenever we're running in-house pathology and doing these biomarkers, those are going to be easily accessible and searchable within the chart. For any external tissue testing, like Caris and Guardant, those are typically sent back to us as like a PDF report. So it's always important to check for that, because that might not flag in a chart. But all of these companies over time, at least at our center, have been integrating the results into an easier to access platform in our EMR, which has also helped to make sure that we're not missing any results that come back.
We want to thank our guests today, Drs. Manish Shah and Sasha Watson. You can head to the show notes for how-to resources on this emerging biomarker. Until next time, for the Cancer Buzz team, this is Summer Johnson.